Hello, everyone. We are going to continue by talking about scabies, and I just want to remind us that the causative organism for scabies is the Sarcoptes scabi mite. We know that this mite tends to burrow into the epidermis of the skin, provoking some inflammatory response, some allergic reactions that brings about pruritus. So because of this severe pruritus, that severe itchiness, that individual tends to scratch that area. The constant scratching brings about the excoriation and a break in the skin barrier. So there are open sores in the skin, which allows for, bacteria to come in. Now, one thing you must always remember for scabies is the nature of the pruritus. So that gives it away quickly. You know, we are going to see in the question stem that the pruritus is going to be intense, number one, and it's going to be worsened at night or after taking hot shower. So there's going to be intense pruritus, which worsens at night or after taking hot shower. So we must have that at the back of our mind. And there is a tendency for secondary bacterial infection, just like I've mentioned, because of the constant scratching, the excoriation, the break in the skin, which allows for entry of, other secondary bacteria like Staphylococcus aureus, causing impetigo, causing cellulitis, and in some individuals leading to sepsis, right? So we should not forget the presenting symptoms, which is intense pruritus, which worsens at night or after taking hot showers. And what are we going to see? We are going to see erythematous papules, with linear tract. With linear tract. So this linear tract is not specific for scabies because we can also see linear patterning in people with bedbug bite, the Simex species. So but it's good to know that we can have that, with scabies, the erythematous, but the location gives it out quickly. We are going to see these papules and the burrows of the mite, where they are embedded within the intertriginous areas of the body, particularly the spaces in between the digits, right? The interdigital finger webs, those are the common sites, the axilla, the flexor areas of the wrist, the genital area. So that individual is going to be having constant scratching of the genitals, constant scratching of the spaces in between the fingers, the axilla, the groin, and the like. So we should have scabies at the back of our mind once we see that that individual is presenting that way and it worsens, at night or after taking hot shower, and we can demonstrate similar lesions, similar presentation in people that are living with that individual. So don't forget that last point. We are going to see in the question stem that similar complaints are made, you know, in within residents that are living closely with that individual. There's another form of scabies we call the crusted scabies or the Norwegian scabies. Very important. So this is more like a more disseminated and severe form of scabies. So this is just an individual having like a more widespread severe form of scabies in which the individual presents with some scaly, crusted, thickened, lesions in the skin. That shows that you have a lot of mite in that person. It's more than 15. Ideally, the normal mild one is less than 15. When you have like a large amount of infestation, more than 15, causing disseminated infection, which are heavy with formation of crusted lesions, with diffuse skin involvement, think about a background immunosuppression. It is only a background immunosuppression that can explain that. So HIV is a very, commonly implicated underlying condition that brings about crusted scabies. So I think I have a picture. I don't know. I think okay, it's closed. Crusted scabies. Let's see. So yeah, so you can see this. Look at this crusting in between the fingers, right? So, stuff like this. This is what we are going to see. So once it shows this picture, we already know what they are talking about. Very straightforward. Um, so history of the pruritus in the family member, just like we have said, you might not be able to see the mite in microscopy, unlike the lice. We talked about the lice, you can see them grossly. Sometimes you might use your dermatoscope, but with the mite, you might need to use your scope to see them. right? So you need to scrape that area and look at it under the microscope to identify the mite, their eggs, and the dropping. So how do you treat? How do you treat? Don't forget the drugs. 5% permethrin, 5% permethrin, or oral ivermectin. Very, very important. So how do you treat them? You just have to wash them with this 5%. Apply this 5% permethrin from the neck down to the legs, or in infants, you have to apply it from the head to the toe, you know, and you have to do it at least 2 times, but 1 week in between, right? So the reason why we are giving it 1 week is because we are allowing for completion of the incubation period. They lay their eggs, they hatch within 1 week. So by the time you're applying it after the next week, you're already catching it in the hatched form. So you can kill off all the remaining, scabies infection. So you apply it this week, you don't apply it the following week, you wait for another week, then you apply it again. So apply it now, wait for 1 week, don't apply it. Then after that 1 week, apply it again. So that you can ensure complete resolution of the mite, or complete eradication rather. Then you can also use oral ivermectin. It's also very effective. It's not only for onchocerciasis. Ivermectin is also indicated in the treatment of scabies, right? So it's not topical like 5% permethrin. It's oral. You have to take it. And for individual with the crusted one, which is a more disseminated one, you combine your oral ivermectin with a topical permethrin, right? So sometimes the pruritus can persist for 2 weeks, yeah. And make sure you clean the fomite. Very, very important stuff, right? You have to clean the fomite, the beds, the clothing, you iron them, you wash them properly, you dry clean them so that they are free from the mite, they are free from the eggs, and everybody can be fine. Now, moving on to the bed bugs. So these are the Cimex species. So the Cimex um, lentularius. These are quite different from scabies because they cause painless erythematous papules, just like scabies. They cause erythematous papules too, like scabies, but they are painless. And they are just like scabies too, they are common at night. But what is going to give it out is the nature of the lesions, right? Because don't because okay, so let me just say that both of them they are puritic. It's just that bed bugs are less puritic compared to scabies, but you know, you might not be able to, get that history of less pruritus, severe pruritus and the likes in the question step. The question will just tell you there's pruritus. And once there's pruritus. So don't use the pruritus to cut them out. Both of them is going to be pruritus and the pruritic rather. And they are both going to get worse, particularly at night. And for bed bugs, it also gets worse in the morning. But what are we going to see? Number one, or most importantly, we are going to see linear, rash, which is painless, and they have a central hemorrhagic punctum. Very, very important. Very, very important. So what you are looking for in the question stem is just this central hemorrhagic punctum. Why? Because the saliva of the bedbugs, they have this anticoagulant, property that allows for, once they take their bite, they can anticoagulate the blood, leading to free flowing of the blood. So that can cause some little bleeding, within the lesions, and that bleeding have some middle or central indentation. So that's what brings about this central hemorrhagic puncture. So you are seeing a purple with a central bleeding with an indentation within it. So think about bedbug. Think about bedbug. It's going to be pruritic. It's going to worsen at night because they come out at night from their crevices. So they typically hide within the beddings, the cushions, the curtain. That's where they hide. So people that live in areas where there is overcrowding, there's poor hygiene, poor sanitation, you tend to have this bed bug hiding within the crevices. So that's why it's most commonly transmitted with exposure to this format rather than person to person, right? So it's been transferred to the infested beddings and furniture. Um, Common at night, and also in the morning. And how do you treat? So you don't give them permethrin or ivermectin. You just, manage the symptoms generally by giving them steroids, and topical steroids and antihistamine, what are you trying to do? You are just trying to minimize the symptoms. That's what you are trying to do. You minimize not particularly the symptoms in terms of the rash, not because they are going to be painless. They have no pain. So you are just trying to relieve the pruritus, the itchiness, and you are trying to, minimize the inflammatory response bringing about the lesions, right? Then what you want to do next is like you want to eradicate the source. And how do you do that? You have to apply insecticide to those areas, to the beds, the furniture, spray them with the insecticide, or use uh heated appliances. So high heat, can also be used to eradicate those bed bugs. So don't forget your painless puritic purples with central hemorrhagic punctum keeps it away quickly. And don't forget your topical steroids and your antihistamine with eradication of the mite with your insecticides and your heat. Then cutaneous liver migrants are what we are familiar with. Everybody knows this, right? We are just going to get a picture of this larva within the leg. Very common in the leg. And what are we going to see? We are going to see erythematous serpentine, so meaning snake-like migratory rash, which is very puritic. You know, so we are going to see erythematous maculopapular, erythematous serpentine migratory rash in the leg. And we are going to see in the question stem that the person is walking barefooted, right? So the hookworm larva can easily gain entry, you know, by penetrating into the intact skin, and migrating through the skin, forming this erythematous snake-like rash. So once you see that, we are thinking about cutaneous liver migrants. So let me show us the picture again so that we have a fresh memory of what we are talking about. Liver migrants, right? So you just see that, rash in the leg. So this is just it. Very easy stuff. We can see this. This individual now having, look at this. You can see the snake-like, maculopapular lesions, right? Erythematous lesion. So, which is going to be migratory. It's going to be changing slowly from that area, migrating upward till it enters the body, right? And the implicating organism is the hookworm infection. So we can see Necator or Encyclostoma. Any one of them in the option, we pick it straight up. Hookworm larva. So very common in people that walk barefooted on the grass or the sand. So you treat by giving your albendazole or you give your ivermectin. Don't forget, never forget that. Ivermectin or your albendazole. So another similar lesion that's close to this is your cutaneous liver currents, right? Which is caused by the um, strongyloides stachyoralis, right? But what is going to give it out is that there's going to be history of, um, you know, the abdominal pain, the vomiting, and duodenitis generally, and there's going to be auto-infection, right? So the person is going to be having recurrent infection from that strongyloides. So that should raise our suspicion. Once we are seeing auto-infection, recurrent symptoms, with the leg, lesions, we can think of strongyloides causing cutaneous liver currents. But if you are seeing something like iron deficiency anemia with this leg infection, no feature of auto-infection, think about hookworm. But most commonly, it's going to be hookworm. But just have an open mind. Read through the question stem. Check if there's any evidence of iron deficiency anemia. If you are seeing that, that is hookworm, right? If there's anything pointing towards recurrent auto-infection, think about your strongyloides. So that's the way to look around it. Moving on to the decubital ulcer, which we also call the pressure ulcers. So very easy. These just occur in areas where there's less fat, right, or there is a bony prominence. When you um when you have too much pressure applied to a bony prominent where there's less fat, there's going to be pressure necrosis of that area because that excessive pressure is going to cut off blood supply to the skin of that region, and it's going to lead to necrosis of the skin with formation of ulcers. You know, very very important. We know that. So these stuff are very common in people that stay on one region for a long time and they don't have recurrent movement, or people that have compromised blood supply, or people that are malnourished, because you need nutrition to heal your skin, right? Or people that have um, impaired cutaneous sensation, maybe from diabetes or something. They cannot even feel that they are applying too much pressure on the part because they don't feel pain, right? So those are these factors for pressure ulcers. We must be able to grade the pressure ulcers. Very easy to grade. You don't need to even cram anything. Very, very easy. Just have an open mind. Stage one to unstageable. Stage one, stage two, stage three, stage four to unstageable. What do we mean by stage one? In stage one, we are not actually seeing any ulcer. What we are just seeing is erythematous lesion that is unblanchable. So, erythematous lesion that is unblanchable. Once you see that in the question stem and they ask you what stage is this, that's stage one. Stage one. There's no breach in the epidermis, no breach in the dermis. You just have erythematous lesion, with a non-blanchable nature, right? For stage two, you already have a breach in the epidermis. So there is a shallow lesion. There's a shallow lesion with a reddish, pinkish ulcer, right? With no slough underneath, and you can see the dermis. So it has already penetrated the epidermis. It has got into the dermis. So you can see a shallow ulcer that looks reddish or pinkish. That is your stage two. So if you look through the ulcer in stage two, you can see the dermis, right? In stage three, just know that what you are seeing in stage three is your subcute. In stage two, what I'm seeing is my dermis. In stage three, what I'm seeing is my subcute. So that means that I have gone through the epidermis, I've gone through the dermis, and I've gotten to the subcute layer. That's stage three. You can see here, we can see the subcute. That is stage three. Stage one, we have not breathed the skin. Erythematous, non-blanchable. Stage two, we have breathed the skin. We have breathed the epidermis. We are seeing the dermis. There's a shallow ulcer, which is red with no slough. In stage three, we have breached the epidermis, we have breached the dermis, we are already seeing the subcute, stage three. In stage four, we have breached um, the epidermis, we have breached the dermis, we have breached the subcute. In fact, we are now seeing the tendon, we are seeing the muscles, right? That is your bone. That is your stage four. So if you have a full thickness lesion breaking through um, the the epidermis, the dermis, the subcute, exposing the tendon, exposing the bone, exposing the muscle. You're already talking about a stage four. But for stage five, I'm sorry about that. For unstageable, there's no stage five. Oh. Please pardon me. My brain is just following the normal reading. After stage four, there is unstageable. There's no stage five. So what happens in unstageable? What we are just trying to say here is that we cannot see through the lesion because the lesion has been covered by slough, necrotic debris. That's it. So when you have ischar, necrotic tissue, slough covering through the ulcer, and you cannot see what is beneath it, what is underneath, then you call it unstageable. So the way you can stage an unstageable pressure ulcer is to clear off the slough so that you can see what you are having. So if it's subcute you are seeing, you know that okay, this is stage three, fine. If it's bone, tendon, muscle that I'm seeing, I know this is stage four. So that is unstageable. Very easy to learn. You don't need to, waste your time. Um, so this is very common in people that are bedridden for a long time and they apply excessive pressure on that area, right? Or areas where you have limited fat. What are these pressure points? The sacrum at the back, the heels of the foot, the top of the first and the fifth metatarsals, right? The ischial tuberosity, right? Those are common pressure areas, even the occiput of the head. So, very common in people that have stayed a long time in the ICU, people that are not moving from time to time, lack mobility, people that sit in wheelchairs for a long time, have reduced mobility, they can have pressure sores. Cutaneous sensation is reduced, diabetes, think about anything. Um, People that get soaked easily, a lot of soaking from urine, from stool can macerate the skin, facilitating ulceration. So you want to keep the skin dry, you know. Um, Your diagnosis is clinical. From your observation and your clinical history, you can make your diagnosis straight up. You don't need to be a genius. You don't need to do any biopsy. You can pinpoint what you are dealing with quickly. But sometimes you might need to do a biopsy, particular when it is non-healing, to rule out squamous cell carcinoma. Because when we start talking about squamous cell carcinoma, you see this non-healing stuff. Once you see a chronic lesion that is expanding and is non-healing, you think about squamous cell carcinoma. You think about squamous cell carcinoma. Or an infection. It could be an infection, chronic infection. Buruli ulcer, for example. You know, or pyodermal gangrenosum. Please don't ever forget pyodermal gangrenosum. It is high yield. You are going to see the ulcer with having like a volaceous purplish border with a purulent base, right? And by the time you do your biopsy, you see a lot of neutrophilic infiltrate, although it's going to be mixed, but you have a lot of neutrophilic, right? And you are going to get an history of the person having either a background malignancy, having a background inflammatory bowel disease, or having um, rheumatoid arthritis. So either of the three, just nail your diagnosis, pyoderma diagnosis. You can just apply your topical steroid or your systemic steroid, depending on the severity. Don't waste your time. Pyoderma diagnosis, high yield. It will start at the nodule and it will start expanding, like that, like that. So you can also do a bone biopsy to diagnose osteomyelitis if there's a bony exposure, which will occur in what stage? In what stage are we going to see osteomyelitis? I know we are saying stage 4. So very important that the stage at which we are going to see the bone is stage 4. So how do you prevent? How do you treat? Prevention is key, right? Anybody that is bedridden for a long time, these ICU guys, you have to put them on the water bed, that can help with the pressure redistribution from time to time. Or if we don't have that facility, the nurses will always be there to shift them from side to side every 2 hours. Very, very important. At least every 2 hours, you know, you have to make sure that you put them on optimal nutrition because that can help with wound healing. Very, very important. You keep their skin dry, you don't want it macerated. um if an ulcer develops, so we are done with the preventive one. So if an ulcer now develops, what do you want to do? You want to ensure that you provide routine wound care. If it's a low grade one, right, you can apply hydrocolloid dressing. So these are just like semi-permeable dressing that have ability to retain moisture in a way, so they can keep that environment moist and facilitate the healing. you know. And for high grade one, you have to apply some complex dressing with surgical debridement. So surgical debridement for the high grade lesion. For the low grade, just apply your hydrocolloid dressing that's going to retain moisture and facilitate the healing quickly. Um, so moving on to gangrene. So gangrene is just necrosis of the body tissue. Very easy. We are not really going to waste too much time. This is something we all know. We have three forms essentially: the dry form, the wet form, and the gas gangrene. Very easy. So the dry gangrene typically occurs when you have impaired blood supply to a tissue. Most of the time it comes from when you have like peripheral arterial disease, either from atherosclerosis, reducing perfusion to an extremity, for example, because the areas where you typically have gangrenes like the extremities, right? So, or like the bowels, you have reduction in blood flow to that extremity, either from occlusion, from fat, deposit, and from there you start having some changes in the skin. The skin is going to start appearing dark, blackish, brownish, you know, and the person might feel pain, and there's going to be cold. If you feel it is going to be cold because of reduced perfusion. Because when you have perfusion to an area, it should provide warmth because blood should deliver heat, right? But if blood is not getting to the area, it will appear cold, it will appear pale. Those are cardinal signs of arterial occlusion, right? So there's going to be like a dull aching pain, there's going to be pallor, and there's going to be cold sensation. Then later on, the necrosis will now set in, death of the skin cells, and you know death of the tissues within that area, with eventual blackish discoloration of the skin. So once you see that, just think about gangrene already setting in. What are the risk factors? Anything that can cause peripheral arterial disease, diabetes, vasculopathy, for my maybe hypertension, right? Smoking is high yield, smoking, hypertension, diabetes, they can all cause peripheral arterial disease, reduce blood flow to the extremity, leading to a dry gangrene. So, once that dry gangrene continues for a long time, you can have superimposed bacterial infection. And when bacterial infection becomes superimposed on it, it becomes wet gangrene. And what are we talking about for wet gangrene? What are we looking at for? Edema. So that area is going to appear swollen. There's going to be formation of blisters with purulent exudate because there's already bacteria in that picture. Bacteria is going to provoke inflammatory response, cardinal signs of inflammation, edema, right? So there's going to be tissue swelling, there's going to be formation of blisters with pus, and it's going to look dirty. That is your wet gangrene. So once you are seeing swollen legs, you are seeing blisters, you are with pus. Think about wet. It's no longer dry. It is now wet. So wet is usually a superimposed liquefactive necrosis on a coagulative necrosis. So the dry gangrene is from the coagulative necrosis, right? From the reduced perfusion, destruction of the tissue. Now, when the bacterial infection comes in, there's liquefaction, formation of pus, the blisters, edema. Now, for the gas gangrene, we don't need to cram too much stuff. What you just need to know is just the predisposing factors. And the two major predisposing factors you must not forget for the sake of your exam is the trauma or surgery. There's going to be trauma or surgery. Sha is going to be there. The person had trauma, the person went for surgery. And these two conditions can compromise blood supply to the tissues. When there's compromise of the blood supply, there's going to be reduction in blood flow, right? There's going to be less delivery of oxygen. There's going to be creation of an anaerobic environment. Now, this is when our guys will now start growing, the anaerobic guys, which is an example, Clostridium perfringens. We should not forget that. Clostridium perfringens is now going to grow into it and it's going to start its own metabolism. It's going to start enjoying its own life. Part of the metabolic product is what? Production of gas. We remember the CO2, they maintain the hydrogen sulfide. And we know that these gas, some of them can be foul smelling, right? So that's why they cause, release of foul smelling discharge, right? There's going to be accumulation of gas. And what happens once this gas is produced? The gas is going to travel within the tissue and is going to separate healthy skin from the affected skin. Now, that healthy skin that is separated it's further exposing that healthy skin to the infection. So the infection will keep spreading to the healthy layers like that, and will keep spreading like that. So, what are we looking out for? We are looking out for inflammatory response, causing discoloration of the skin, formation of black brownish bullae. That's number one. There's going to be formation of black brownish bullae in response to the inflammation from that infection, number one. And number two, what is going to heighten our suspicion is the crepitus. The crepitus. The crepitus. The crepitus is just like the crackling sounds from accumulation of the gas. Very important. So once you see gas, we know that this is going to be an anaerobic infection causing gas gangrene. What is this infection? Clostridium perfringens. What is the last thing to remember? The foul-smelling putrid discharge. Those three things, think about gas gangrene. The bullous lesion with skin discoloration, the crepitus from the gas accumulation, and the foul-smelling putrid discharge. Gas gangrene. Gas gangrene. So don't forget the gas accumulation. It is a medical emergency. You must do your debridement. If there's a need for amputation, amputate, right? Place on thorough antibiotic cover immediately after your surgery because you cannot start with antibiotics. There's no blood flow. Don't forget, the initial starting problem is that there's no blood flow. So how is the drug going to get to that area when there's no blood flow? So debride, remove all the necrotic tissue, do your amputation if it's necessary, place on antibiotic cover. So IV drug use are another risk factor. It can can cause a trauma to the skin and allowing introduction of the bacteria, right? So don't forget the swelling, the peak down dark red skin around the side of the injury, and the anaerobic environment, which usually follows trauma and surgery. Don't forget that. Don't forget. Don't forget. So sometimes your diagnosis, is usually clinical. From your exam findings, you can feel for the crepitors from the history. But sometimes, if you want to further more your investigation, you can do your CT scan, your X-ray rather. You can do your X-ray, and you are going to see these dark areas which indicate hair tracking in the tissue. So you can see these dark areas beneath. So that is suggestive of your gas gangrene. You know, so how do you treat? Um, your surgical debridement, very important. Amputate if it's necessary. These two are is just the mainstay of treatment. You cannot give antibiotics because of the impairment of blood flow, right? But you can do it after your surgery, adjuvant to surgery. Sometimes you might need to apply hyperbaric oxygen. So it might be hyperbaric oxygen that you are going to see in the question, and that is just trying to, eliminate that anaerobic situation so that the oxygen is going to come in and destroy the Clostridium perfringens, because these guys cannot survive where you have a lot of oxygen. So it's common sense to just apply hyperbaric, oxygen to kill off anything that cannot survive when there's oxygen. Um, so the antibiotics I will give, should include like penicillin for the gram positive, because don't forget stuff like strep can also come into the picture and can cause something similar to this. And give your clindamycin to take care of your anaerobes. Pen and clindamycin is commonly used, after your surgery. Um, so moving on to the miscellaneous skin disorders, and we are going to talk about stasis dermatitis. So stasis dermatitis just meaning you are having stasis, accumulation of blood, venous blood majorly, you know, leading to eventual skin changes, skin discoloration, you know, and sometimes they can progress to even cause skin ulcers, right? Stasis dermatitis. Now, what is the starting problem? The starting problem is anything causing venous hypertension. And I think I have a list of them. Anything that causes venous hypertension is going to lead to stasis dermatitis. And what are these risk factors? Older people, pregnant people, obese people, people with recurrent DVTs. All these things can, for example, DVT can cause occlusion of venous drainage. So people with incompetent valves, right? People that stand, people that are pregnant that, they are not mobile frequently, people that smoke, obese people, all these conditions cause elevation of the venous pressure. So the way the smoking is related to it, the pathophysiology is not well established, but there's a high risk of smokers having venous hypertension. And because of the constant pooling of blood within that distal extremity, you have like, a distension of the pressure, blood accumulation within the veins. And what happens? To cut the story short, so that I don't take us through the long route, we should know that it's going to cause a break within the capillary. So you know that what is next to the veins is the capillary, right? Before we get to the arteries. So the venous pressure is going to get transmitted to the capillaries, and it's going to open up the capillaries. And what will happen? You are going to have extravasation of fluid, blood containing red blood cells, containing plasma protein, containing leukocytes. They are going to go into the interstitial space, right? Now, you're having your red blood cells moving into the interstitial space. Red blood cell contain hemoglobin. Part of the pigment, from hemoglobin is hemosiderin. So hemosiderin is going to accumulate in that area and impact some discoloration to that skin. The leukocytes are going to release their cytokines, which is going to lead to inflammation with eventual, atrophy, skin damage, and ulcer formation. So all these ulcer we are seeing now is from the inflammatory response from the leukocytes. The discoloration is also from accumulation of hemosiderin pigment from release of hemoglobin from the red blood cell breakdown. That's what we see. So once you see this dry eczematous, so that's how it's going to be described for you in the question stem. A dry eczematous lesion, which might be pruritic, located above the medial part of the ankle. That is the commonest side of venous dermatitis. You know, the medial side of the ankle, think about a venous problem. When you see the ulcer located within the medial side of the ankle, the upper part of the medial ankle, you call that the gator area. You know, think about stasis dermatitis leading to venous ulcer. So that is how the pathophysiology works. I hope we get that. So sometimes it might be history of DVT, recurrent DVT that occludes the venous drainage, blood will pool within the vein, venous hypertension, then the blood will flow through the capillary, open up the capillary with extravasation of blood through the capillaries. People that stand for a long time, all these things can increase venous pressure. So the area will become inflamed, exudative, hyperpigmented, from hemosiderin deposition. Stasis ulcer can develop, particularly at the gatal area, the superior medial aspect of the ankle. How do you avoid all these things? How do you avoid your stasis dermatitis? You have to ensure early leg elevation. Elevate that leg, bring it up so that you can increase venous return, right? Apply compression stockings. Once you apply compression stockings, you are going to squeeze the veins and you are going to increase the venous return. Very important. You are going to reduce venous compliance. You reduce venous capacitance. So when you reduce venous capacitance, they cannot have the capacity to accommodate blood. So that means that they will have to push the blood back to the heart, right? Apply your emollient because of the enzymatous appearance. Keep it supple and clean and nice. Emollient because it's already dry. Then apply your topical steroid to limit the inflammatory response. So most importantly, raise the leg, apply compression stockings. Those are the two important ones. Then you can apply your emollient and topical steroid to minimize its appearance. Moving on to the next one. The next one is acanthosis nigricans. Very easy. We already know this from our step one. What are we looking out for? We are just going to see the individual having hyperpigmented, hyperkeratotic lesions within the intratriginous areas, particularly the axilla. So once we see an individual having hyperpigmented, what do I mean? Dark lesions like this, which are hyperkeratotic. There is thickening of the stratum corneum. Hyperkeratotic, hyperpigmented lesions with vervity appearance. This kind of constant skin breaking, appearance. Like this, once you see this is what we call the vervity appearance within the intratriginous area. Think about acanthosis nigricans. The next thing you want to do is to go and look for the BMI. What is this patient BMI? Is it more than 30? Yeah, this patient is obese. So this is a cause. Now, what is the major implicating factor for this acanthosis nigricans, the hyperkeratosis and the hyperpigmentation is, increased proliferative activity due to insulin resistance. So once you have a lot of insulin, insulin can promote growth of the skin tissue like this. So, and what can cause insulin to accumulate is when you have insulin resistance. When the body is not responding to insulin, the body will keep trying to produce more insulin to see if that's going to solve the problem, right? The body is just deceiving itself. So that will make a lot of insulin to be produced, and the insulin will start exerting a trophic effect on the skin, particularly within the intertriginous areas. Now, what are those conditions that can cause insulin resistance? A patient that is obese, a patient that has type 2 DM, right? A patient that is having PCOS is going to be obese. A patient that has Cushing disease, Cushing syndrome, they are going to be obese. So those are the ones that follow the pathway of insulin resistance. There's another form that relates to malignancy. So people with gastric cancer too can have this. So that is a malignant form. So we should have that at the back of our mind. Very important we remember that. So um you don't treat it. You don't treat it. You just encourage the patient to lose weight and you treat the underlying condition. Okay. So it can be a paraneoplastic sign in people with underlying GI adenocarcinoma. Otherwise, if the person doesn't have any sign of malignancy, it's just coming from insulin resistance. And that can be from DM, from Cushing disease, from PCOS, or from, obesity, from any cause. You don't treat that lesion directly, you have to treat the underlying cause, right? If the person obeys, encourage weight loss and treat the underlying endocrinopathy from Cushing disease, from diabetes and the likes. Moving on to lichen planus. Lichen planus is a twin brother um for psoriasis, right? But unlike psoriasis, it occurs more within the flexural area, while psoriasis occurs at the extensor surface. So lichen planus is usually self-limited, right? It resolve on its own most times, but the problem with it is that it is a chronic lesion. So they recur time to time. So and you must always remember the six P's of lichen. In fact, by the time you are reading the question stem, you have already picked your six P's, your three or four P's, and you have made your diagnosis. And what are the P's? The planner, the nature of the lesion. So they appear flat. They have a flat top. They are violaceous. They have purple color. But this purple color is very prominent when you are looking at a black lesion, black skin. So if you are looking at a white skin, it might not really have that purplish appearance per se. They're polygonal in shape, well-defined polygonal shape. They are puritic. They are puritic and they are papules and plaques. So, papulosquamous, just like psoriasis. So you have papules, you have plaques. They are puritic, they are polygonal, they are planar, they have a flat top, and they are purplish in color. So don't forget they can be evoked by use of some certain medications. Thiazide, quinine, beta blockers, ACE inhibitors.
Yeah, so as I was saying, we should not forget the peas, the planar nature, because it has a flat top, the fatter is purplish in color, it's polygonal in shape, it's puritic, and they are papulosquamous. That means they are made up of plaques and papules, right? We shouldn't forget the inducing drugs, which include the thiazide, the ACIs, the quinines, hydroxychloroquine, beta blockers. Just know a few. you know, and the fact that it is associated with HCV. We cannot go to that exam and not remember that lichen planus is associated with hepatitis C infection. So by the time we are seeing hepatitis C infection, the previous history of hepatitis C infection, we think about some dermatologic complications like lichen planus. We think about leukocytoclastic vasculitis, right? Um, you know, um, so those are the common dermatologic problems you see in people with hepatitis C infection. So we should have that at the back of our mind. Um, so we have talked about the way they look like. They are purplish, flat topped, purple, and don't forget the regions where you find lichen planus. You typically see them in the skin, particularly the flexor areas. The anterior part of the wrist, the forearm. You see them in the mucosal surface, particularly the genitals and the oral mucosa. So it can affect the oral mucosa. I know when we're doing the GIT section, Dr. Babarinde will have told us about the oral lichen planus, what affect the oral mucosa, right? Which has a predisposition to malignancy in few, maybe 2 or 3% of cases, and the one that affect the genitals. So once you see the P is being described at this typical location, the flexor area of the extremity, and the mucosa, the oral mucosa, genital mucosa, think about lichen planus. And what are you going to see for the mucosal lesions? You are going to see white reticular lines, which you call the Wickham striae. Very important stuff. You see the Wickham striae, the lacy reticular white lines in the mucosa. So once it affects the mucosa, that is what you are going to see. So it also shows the Koebner phenomenon, just like psoriasis. Once you apply trauma, you are going to see the new lesions, developing at that site of trauma. Um, so these are the lesions, the plaques, the papules, the plaques forming within the flexural area of the wrist. Sometimes they might want you to pick the histologic characteristics of um this presentation, this disease in the option. So you have to remember the fact that there is hypergranulosis. That means there is hypertrophy or hyperplasia of the stratum granulosum layer, while the stratum corneum is absent. Don't forget that. The opposite is for psoriasis. So there's hypergranulosis. Let me put it here so that we can see this. Hypergranulosis, hyperplasia of the stratum granulosus layer, which is like the third layer. Hypergranulosis. Then you have sawtooth infiltrate. Um, Sawtooth infiltrate at the demo, epidermal junction. Epidermal junction. So sawtooth lymphocytic infiltrate. So the lymphocyte will be seen there, biopsy at the dermoepidermal junction. So either of these will be corrected by Leica planners. When I was talking about the hepatitis C, what I was trying to remember, Leica planners, leukocytoclastic vasculitis, and porphyria cutanea alterata. Porphyria cutanea alterata. I think have we talked about porphyria? No. So what you are going to see is just history of somebody having these blisters, erosions at the back of the hand, especially where there's sun exposure. So areas at the back of the hand, and that areas are going to heal by scarring. Once you see that kind of presentation, hepatitis C background infection, and the person is having, blisters at the back of the hand that heals with scarring, just go and pick your porphyria cutanea alterata and move. So those are three dermatological manifestations of hepatitis C. So how do you want to treat? Very easy. If it's minimal, just apply topical steroid. If it's widespread, use oral steroid, right? Use oral steroid. Sometimes, you can use phototherapy. Most of the time, the question will not go beyond steroid. Topical steroid, systemic steroid. So moving on to rosacea. So rosacea is just a chronic disorder. Rosacea is a chronic disorder affecting the pilosebaceous unit. So the etiology is not clear. Some studies believe it's due to inflammatory response to some skin infection. Some say it's due to skin damage from UV, from ultraviolet radiation exposure. Some say it's due to vasomotor dysfunction in the skin. So we don't need to, memorize all those things. What is important to us is the manifestation. So how do we see someone that has rosacea? So you are going to get the picture or the history that somebody is having some rash within the anterior aspect of the face. And this rash doesn't typically spread in nasolabial foot. Right. So you'll not be thinking of SLE or DLE. It affects the nasolabial fold and moves from the cheek to the nose, sometimes with the upper part of the face. And most commonly, we are going to get that the person is having flushing. So there's flushing, there's erythema, and there's telangiectasia. Once we see that, we think about rosacea. Flushing, erythema, telangiectasia, small dilated arteries which have the spider lag configuration. Think about rosacea. The flushing is very important. The flushing can occur maybe following sun exposure. It can occur after taking spicy drink, after taking hot drinks, after, maybe emotional stress, right? So we have to categorize into types. The one I've just said now is the commonest form, which is the erythema telangiectasic rosacea. So look at the word erythema, skin redness, right? Telangiectasis, formation of telangiectasia in the skin, right? So we are going to have that central facial erythema with telangiectasia. So once you have that in the question stem, think about rosacea, especially if it's aggravated by sun exposure, if it's aggravated by taking hot drinks or spicy foods. You think about or alcohol, especially alcohol. Think about rosacea. So that's the erythematotelangiectasia form. Erythematotelangiectasia form. And that form is a papulopustula. So they won't tell us that there's telangiectasia, but they'll tell us that there's papules and pustules, confined to this anterior aspect of the face. In a old man, develop papules and pustules only. That's the papulopustular, right? That's the second commonest form. Then we have the phimosis rosacea. So this phimosis one is just talking about thickening of the skin due to deposition of fibrous tissue. So the sebaceous gland, the skin, they all look dilated, bulbous, and thickened. So especially in the nose, look at this man's nose now. It looks bulbous. It looks big. So this is like combined like the phimosis form with the um with the erythemato erythematotalangiectasis. So although I'm not really seeing telangiectasia here, I'm not seeing telangiectasia here. So let's just say this is phimosis form, with the facial flushing, right? So this is the phimosis rosacea. You can see the bulbous dilatation of the nose. That's just what you are looking out for. So if the question says that there is bulbous enlargement of the nose, you know that they are talking about the phimosis rosacea, and this is due to overgrowth of uh, connective tissue in the chin, the forehead, and the nose, particularly the nose causing rhinophyma. What's the last form? The last one is the ocular rosacea. Ocular rosacea. So this person is going to be having the facial flushing too, but they'll be having some manifestations involving the eyes. And what are we talking about? We can get the history that the eye is inflamed, it's red, particularly the eyelid, causing blepharitis. You see evidence of style, pus formation within the eyelid, which is painful because of occlusion of the meibomian gland with superimposition of staph aureus, causing painful eye lesions, right? And swelling. And of course, chalazion. Chalazion is just like the milder form of style. There's occlusion of the meibomian gland, but there's no bacterial infections there. So it's just like the eye swelling, and it has minimal pain. So sometimes they can tell us they have lid margin telangiectasia. They have conjunctival redness. Once you are seeing all those things with the facial flushing, think about ocular rosacea. So let's take it again. The erythematotelangiectasia, the redness, telangiectasia. The papulopustular, you are just saying papus, you are saying pustules. The phimosis, there is bulbous dilatation of the face, the nose especially, causing rhinophyma. Then the ocular, we are seeing high redness, lid margin telangiectasia, stye, eye swellings, and the like. Think about ocular rosacea. So this is very common in people that are fair-skinned and they have abnormal flushing response, to hot spicy drinks, hot drinks rather, spicy food, alcohol, sun exposure, and there's a female predominant, right? So don't forget the triggers. This trigger gives it away quickly. The spicy food, the hot drinks, alcohol, sun exposure. So it's being referred to adult acne because it presents similarly as acne, but involve other age group. Yeah. So we need to know the way to manage them. You know, so you have to ensure lifestyle modification, behavioral modification. Avoid exposure to sunlight and alcohol. So you can just minimize the sunlight, right? Just maybe by wearing some um hats, to cover your head. You know, um, coming out outside the peak hours of sunlight, like avoid coming out between 10 a.m. to 4 a.m. 4 p.m. But it's not virtually, it's impractical, right? So just if there's sunlight avoidance in the question, please pick it. Alcohol avoidance, pick it. Minimize spicy foods, minimize taking hot drinks. Those are the trigger. Keep your skin healthy. Emollient use, you know, just keep it soft and supple. But the specific ones, which you are going to see in the questions there, erythematotelangiectasis. So here you just have like vasodilation of vessels causing, the formation of the telangiectasia and the erythema. So what you want to do is just to give a alpha 2 agonist. So if you give a alpha 2 agonist, it's going to constrict the vessels and, they are going to minimize the vasodilation. That's where I look at it. So an example is brimonidine. So when you give brimonidine, it's going to take care of the erythemotelangiectasia form. Or you can give laser therapy if that doesn't work. But most of the time, your topical brimonidine, which is an alpha 2 agonist, will do the work, will do the job. Then the papulopustular one, I just imagine that there's infection here, anaerobic infection probably. So let me give metronidazole. So for the papulopustular rosacea, you give topical metronidazole. Of course, because you are seeing pustules, just think about infection. Metronidazole is the drug of choice. The phimosis one, you want to give oral isotretinoin to take care of it, or laser therapy. So you have to get familiar with these drugs. Phimosis one, this excessive deposition of collagen, you give isotretinoin, and laser. For the ocular one, give antibiotics too. And what antibiotics are we giving? Not metro, but doxycycline. Oral doxycycline. Oral doxycycline. So we can look at them again. The erythematotelangiectatic you want to vasoconstrict, right? Brimonidine or laser. Postular one, papillopostular, there's infection, anaerobic infection, right? Let's give topical metronidazole, right? For the phimosis, there's, excessive connective tissue deposition, give isotretinoin or your laser therapy. Then for the ocular one, give your oral doxycycline. So that's where it works. Pityriasis rosea. So this is very simple. Most of the time it follows a viral infection, which is the human herpes virus type 7 most of the time, right? It follows this particular infection. Don't forget, human herpes virus type 7, you know, and that is why before the onset of the rash, you are going to get a prodromal symptom. So the patient is going to complain of fever, headache, malaise, weakness, viral prodrome. Then you are going to see the first rash, and the initial lesion you are going to see is what we call the Erad patch. So we are already familiar with this. This is just an erythematous plaque with a peripheral scale. It is an erythematous plaque with a peripheral scale. What are we looking at? A patch, rather, erythematous patch is not raised, with a peripheral scale. It's a flat lesion. Look at this. It has been magnified for us. This is what it looks like. This patch. You can see the scaling, right? That is your Erad patch. And you typically see it in the trunk. So once they tell us in the question stem that somebody has fever, has malaise, headache, then subsequently the person develops, an erythematous annular patch with a peripheral scale in the trunk. We know they are describing the Erad patch, so we should start thinking about pityriasis rosea. Please, not pityriasis versicolor. Pityriasis rosea is not fungal, it's due to viral HHV type 7. Then after some few weeks or days, the major rash will now start appearing, the maculopapular rash. You see some secondary eruption, which are erythematous, papules or plaques that appears along the tension lines of the skin. So they arrange along the skin lines. They are going to mention it like that in the question stem to guide us. And they follow this classic Christmas tree appearance. So they spread upwards, downwards, looking like configuration of a Christmas tree. These are the rash, that appear afterwards. So once you don't need to even, have too much stuff. Once you know that, okay, the viral prodrome has been established, you can see the errad patch. Then subsequently, they said the person start developing some plaques or papules, along the skin line. This is pityriasis rosea. Just go and pick your answer and you move. And the subsequent rash occurs more at the back, right? They are very common at the back. Don't forget that. They are very common at the back. So don't forget it's due to human herpes virus type 7. What do you want to do? You don't need to do anything. And don't forget it spares the palm and the sole, unlike syphilis. So you don't need to do anything. The diagnosis is clinical. Sometimes you might need to do KOH mantin to separate it from tinea corporis, and also need to do maybe your VDRA test, to separate it from authoritative antibody test to separate from secondary syphilis. The rash is self-resolving, just like lichen planus. Most of the time they self-resolve. You don't do anything here in pityriasis rosea, although you might give topical corticosteroid in lichen planus. Here, you don't do anything. They will go by themselves within 6 to 7, 8 weeks. It will resolve. But because you want to treat some of the symptoms, right? It can be pruritic. So you want to give your antihistamine, you want to give your emollient. That's just all. The rash, they will go on their own within 6 to 8 weeks. Yeah. So moving on to vitiligo. So vitiligo is caused by autoimmune destruction of the melanocytes. So there is destruction of the melanocytes, there is reduction in the melanocyte, and there is reduction in melanin production. So when this happens, you are going to have a patchy depigmentation of the skin, and the lesions are going to be well demarcated. They are going to be well demarcated, and you have to have it at the back of your mind that if you are seeing somebody having vitiligo, you must rule out other autoimmune disease. This is very, very important stuff. And the most commonly associated autoimmune disease is hypothyroidism. Hypothyroidism. So you must do a TSH analysis. You must do a TSH analysis. Very, very important stuff. So other autoimmune disease also present, like type 1 DM, can be present. Uh, Pernicious anemia can be there. They can have other autoimmune, but the most common one is hypothyroidism. If you see antibody analysis for SLE, don't pick it because it's not very very, very commonly associated with vitiligo, right? Don't pick it. So the one you want to rule out first is like hypothyroidism, TSH, type 1 DM, pernicious anemia, and like. So, but don't forget the hypothyroidism, very, very important. How does the lesion appear? So just remember the way lichen planus appear. Lichen planus affect skin, it affects the mucosa, right? Same here in vitiligo. Vitiligo affect the skin, particularly the skin of the digits, the sacral, like the hands, the toes, right? The fingers, the toes, the mucosa, right? The genital mucosa, and so oral mucosa, and sometimes it is segmental, just a particular dermatome is involved. Just see a particular segment of the body having this well demarcated, deep pigmentation of the skin. You just see this hypopigmented lesion because you have taken out the melanocyte in that area. There's autoimmune destruction of the melanocytes. Vitiligo is an autoimmune disease. So it can affect the hand, the face, the genitalia, right? And they usually start at any age, but it progresses slowly. It progresses slowly, and you can have repigmentation in some situations, right? So the diagnosis is clinical. You have to check for serologic markers of autoimmune disease, particularly your antithyroid, for your um, hypothyroidism, Hashimoto and the likes, type 1 DM, the GAD antibodies, and also antibody against intrinsic factor, excuse me, for pernicious anemia. So they are occasionally present within this. So those three ones are very common. Thyroid problem, type 1 DM, and pernicious. Most commonly, thyroid issues. No, most commonly, thyroid issues. So don't forget the diagnosis, clinical. Once you see the lesions, what you are going to pick is, if they tell you what will you need to make the diagnosis, just pick. You don't do anything. It's clinical. So sometimes you might need to do histologic examination, and that will show you, absence of the melanocytes. You will not see any melanocytes because they are destroyed, by the autoantibodies, and there's no production of melanin pigment, of course. Sometimes if you do your wood lamp examination, you can differentiate the normal skin from the hypopigmented lesion. It's going to make it um, um, evident. So they are going to show more with the wood lamp. How do you treat? How do you treat? So most of the time, you just apply your steroid, topical steroid. So depending on the extent. So if it's mild, you can confine it, maybe just the hands only. Just apply your topical steroid to that area, right? If it's widespread, you have to give oral steroids. Your oral steroid will take care of the widespread lesion. It will reduce their progression at the same time. So don't forget, just like lichen planus, if it's minimal, just give topical steroid. If it's widespread, use oral steroid. If oral steroid does not work, you can give your topical calcineurin inhibitors, right? Like your tacrolimus ointment. You can use your tacrolimus ointment sometimes. You can use your JAK inhibitors like baricitinib. You can give phototherapy, UV light exposure, and laser therapy. Most of the time, it won't get to this because all these are even used in stable vitiligo is when it's stable. When it is highly progressive, because the ideal pattern of vitiligo is that it is slowly progressive. So you can just give your topical steroids. If that doesn't work, give your calcineurin inhibitors, tacrolimus. If that doesn't work, you can consider phototherapy or giving laser therapy or your JAK inhibitors, baricitinib, right? But if you see in the question standard, they said it's fast spreading, give oral steroids. Very important stuff. Very important stuff. So some people might need to apply this sunscreen, the sun protective factor 30, to prevent burn because the skin is liable to burn injury. Some can apply some dark colored makeup to cover those hypopigmentation so that you know they can appear um, cosmetically, okay, just to cover up those lesions, cosmetics, right? Um, So that's that about vitiligo.